Good morning, everyone. Today I'll be presenting my research proposal titled Software Validation for Nuclear Medicine Safety, a study of dose rates and phantom measurements of radioisotopes used in both nuclear medicine imaging and therapy procedures. My name's Josh, and my supervisors for this project are Mario, Christine, Rick, Paul, and Pejman. So the reason for performing this research is that when patients are administered radiopharmaceuticals for diagnostic imaging or therapeutic procedures, they become sources of radiation external exposure. This raises concerns with non-radiation healthcare workers, such as sonographers, and the general public. These groups are unmonitored, meaning that they're not occupationally monitored for their radiation external exposure. Patients can also be apprehensive about receiving treatments as they fear for how much radiation they're exposing to their loved ones. The lack of education amongst healthcare providers is the main reason for this radiation phobia, with some healthcare professionals refusing to perform procedures that involve nuclear medicine patients. So the main aim of this project is to validate the software NUMEX, Nuclear Medicine External Exposures. The software NUMEX is currently employed at the Department of Medical Technology and Physics and the Department of Nuclear Medicine at Sir Charles Gairdner Hospital. The software is based on an in-house spreadsheet which was developed at MTP. The software has input parameters for the administered activity of the radioisotope, the distance to the patient, and the duration of a contact with a nuclear medicine patient. The cumulative dose is then calculated for this contact. Currently, NUMEX only supports radioisotopes that are used for diagnostic imaging. These include technetium-99m and fluorine-18. I also plan on validating radioisotopes that are used for therapies. There's an emphasis on this as these radionuclides pose more significant health risks and concerns regarding these are generally higher. To validate my measurements, I'll be comparing with the literature and also in-house patient measurements at Sir Charles Gairdner Hospital. For lutetium-177 therapy, I'll be looking at clinical trials data. This project also aims to explore the uniformity of activity distributions for radionuclides on NEMA water phantoms via SPECT imaging. So this is the setup that will be used for all the measurements in this research project. I'll be using the same calibrated fluke ionization chamber to measure the dose rates. This will be rested on an elevated setup made of plastic sheet and blocks of polystyrene foam taped together. This creates an elevated environment which causes a scatter-free environment, which is ideal for my measurements. It is also low cost. As you can see, I'll be dragging the ionization chamber to each increment of distance. So this minimizes the human error element. This setup also has high reproducibility for all the radionuclides. So I'll be using water phantoms for 3 of the radioisotopes and a thyroid neck phantom for the iodine-131 measurements. The water phantoms will be filled with a homogeneous mixture of water and radioisotopes. I'll also be measuring point and line sources. These will be the unattenuated exposures. I'll be performing 3 measurements with the phantoms at different orientations. These include posterior, anterior, and lateral orientations. Before each measurement, the activity of the radionuclide will need to be measured. This is done in a radioisotope dose calibrator, as you can see on both of the images on the right. This will help generate normalized decay-corrected dose rate curves, which I will show later on. I've also 3D printed a hollow cylindrical vial or a dipper in Fusion 360 and Bamboo Lab for the handling of the radionuclide. This also reduces the air scatter within the thyroid neck phantom for the iodine-131 measurements. The main challenges and limitations of this project are understanding discrepancies within the literature, as there are various approaches and methodologies used. There is more data on certain radioisotopes than others. For example, because iodine-131 has been used for therapy since the 1940s, there is a lot more data and research on external exposures for that radionuclide than comparatively with lutetium-177 therapies. The measurements for this project are subject to the availability of the radioisotopes, so sometimes I'll be waiting for leftover doses or patient cancellations. Finally, my supervisors are full-time clinical medical physicists, so their clinical duties and patients are their top priority. Successful validation of the NUMEX software will improve the legitimacy of this individualized tailored model. Its user-friendly graphical user interface can be used by radiation workers and non-radiation workers alike to assess which safety precautions should be implemented and adhered to when interacting with nuclear medicine patients. This information can be exported in PDF format and be relayed to caregivers of the patient to ensure everyone, including the general public, have minimal radiation external exposure. This software can and has been used to delay procedures, subsequently reducing the occupational exposure of healthcare workers. It can also be used to plan and schedule treatments more efficiently and alleviate any health concerns. This research project follows on from a previous project, from Christine's project, my co-supervisor, which investigated modelling the external radiation exposure to healthcare workers and the public from nuclear medicine imaging patients. She developed a user-friendly software which provides tailored radiation safety precautions depending on calculated cumulative doses and selected groups interacting with that patient. This software has the potential for clinical implementation and publication if our successful phantom measurements and subsequently patient measurements correlate to the model appropriately. It's well documented from many sources that the line source model is in better agreement with experimental data, as the point source tends to overestimate, especially at close distances, and is overly conservative. Williganian et al. And Yi et al. Have suggested correction factors or self-shielding factors for correcting overestimations for the unattenuated point and line sources. This increases the accuracy and has more reasonable data which can be used for determining patient discharge criteria. Djukelic et al. Compared different source models which included the volume source model. They found that the volume source model was more realistic than both the line source model and the point source model. They used Monte Carlo simulations to calculate the volume source models. Despite this, the line source model is still preferred due to its easier implementation of dose calculation. Monte Carlo methods are also too time-consuming and not practical for a per-patient release basis. Radionuclide therapy close contact dose program, or the spreadsheet, was developed by Cormack and Shearer in 1998 using Microsoft Excel. Their spreadsheet has been implemented in Australian hospitals over the last 2 decades. The spreadsheet includes an approximation in the calculation of dose from a contact pattern. This significantly affects the calculated restriction period. So in 2023, Forster et al. Developed a new software called DAWN, Delay or Not, where this approximation was discarded. They found it had higher accuracy for calculating restriction periods. Brayshaw et al. In the same year proposed a method based on conservative estimations of the whole body retention function and at least one measurement of the nuclear medicine patient's dose rate. This adds an element of personalization to the restriction period calculations and typically compensates for the conservative retention functions in most cases. So this is my research plan. I plan on doing point source measurements, line source measurements, and phantom measurements for 4 radioisotopes. The iodine-131 and lutetium-177 will be the radioisotopes used for therapy, and fluorine-18 and technetium-99m will be the radioisotopes used for diagnostic imaging. So I've been lucky enough to start my research rather early, and I've already completed a quarter of all my planned measurements. As I previously mentioned, the measurements of these radioisotopes are subject to their availability. So for fluorine-18 and technetium-99M, these can be freely ordered, so I can plan accordingly. Conversely, for iodine-131, I'll be relying on patient cancellation of doses, so these will be a lot harder to plan. And lutetium-177 is a bit of an intermediate. I'll be using leftover patient doses for treatments, and typically there is always leftovers. After all the measurements have been performed, I plan on performing a regression analysis to find the best fits for the normalized decay-corrected dose rate curves. I'll be comparing with the literature, and I'll also be comparing with the NUMEC software, at least for technetium-99M and fluorine-18. I plan on also comparing with other softwares, such as the freely available Dawn. And finally, I'll be comparing the lutetium-177 with retention calculations and the clinical trials data. So this is some data I've already collected from the iodine-131 phantom measurements. As you can see, the dose rates for the anterior orientation has the highest amount of external exposure. And this is due to the least amount of attenuation from the source to the detector. And the posterior orientation has the least amount of external exposure due to the most amount of attenuation to the detector, and the lateral is in between these two. I've used a mono-exponential fit for these models, but I plan on exploring bi-exponential fits to hopefully achieve a higher R-squared value. To conclude, it is important to know when to discharge nuclear medicine patients so we can assess the potential exposures to others. A close contact restriction period, if implemented, should be patient-specific. The provider of a nuclear medicine procedure is legally required to ensure that no member of the public receives an effective dose greater than the prescribed limit of 1 millisievert, as outlined by the ICRP 103 report. Models such as the line source that are reasonably approximate across a variety of distances can be used as a foundation for software to be developed, such as Dawn and the software NUMECs. These provide accurate restriction periods for patients. And accurate restriction periods avoid unnecessary hospital confinement and isolations. Meaningful instructions will probably lead to shorter restriction times, which most patients will enjoy. This improved quality of life, lower costs for the medical institutions involved, and the therapy provider can also be more confident in their compliance with regulatory requirements and best practices. As well as my supervisors, I'd like to thank the medical technology and physics team for supplying me a TLD badge and also letting me use their outpatient room for all my measurements. I'd also like to thank Ashleisha for teaching me and demonstrating Fusion 360 and Bamboo Lab software for my 3D printed dipper. Thank you so much for listening. Does anyone have any questions?
Thanks, Josh. Excellent presentation. Good to see you've already made some substantial progress. I might jump in for a quick question and then I'll throw over to Mashid and Martin and the rest after that. So you mentioned that the software currently works for technetium-99M and F18. I was wondering if it also works for other common diagnostic radioisotopes such as gallium-68.
Yes, so there is a list in Christine's thesis that has a list of all the procedures that were performed at Sir Charles Gardner Hospital. And I'm pretty sure those included gallium scans. So there's a few different ones.
Yeah, gotcha.
It includes a wide variety of radioisotopes.
Sure. Okay. Thanks, Josh. Mashid.
Thank you. Very nice project, well defined, and great that you have had some progress. So my question is about the fluke detector that you mentioned you're using for those rate measurements. So what type of detector is that?
It's a fluke ionization chamber.
Okay, good. And then, so is it common practice to use these detectors for such measurements?
I think so. I think they're most commonly used for like surveying, like a survey meter.
Yes, good.
It's probably not common practice to use it in the orientation I've got it, but
Yes.
yes, I think it is commonly used.
So why don't you use the direction that is indicated on it?
Because we tried it with it having it like upways, but it was leaning forward too much. And
I see.
because the calibration point is about 4.5 centimeters in the center of the detector, I wanted to have it as uniformly flat as possible. So it's just to try and maximize accuracy of the measurement.
Excellent. Then you mentioned about the activities that are leftovers or if patients get cancelled. So then what level of activity do you usually get?
So last week I was using lutetium-177, and as you can see, that had an activity of 3.15 gig. So the radionuclides used for therapy, they have quite higher activities than the iodine one. I think the iodine one was about 128 megabecquerels.
Right. So how does that activity affect your uncertainty of measurement?
I'm not entirely sure. For the errors, I'll just be using like absolute errors from the fluke device itself. I've got documents that say it's calibrated error, so I'll just be using that. So I'm not entirely sure how the activity will play into that.
Okay.
I would expect activities, higher activities would have less error.
Yes. So it may be something to think about. And did you mention the energy of the radioisotopes you're measuring?
No, I didn't mention the
Okay.
energy of the radioisotopes.
Would that have any effect on your measurements?
I'm not sure if it had any effect on the measurements, but the external exposures, you'd have more dose at farther distances for radionuclides that are emitting higher energy gamma photons.
Right.
So
thank you very
it'd
much.
be more signal, but yeah.
Thank you.
Thanks, Bashir. Martin?
What you're doing basically is when you're doing the validation is you're looking at how accurate the calculations are from the model, and then how the different source models impact that accuracy. And you may have mentioned it, but I guess at some point there'll be a tolerance, and within that tolerance you'll say the calculation is valid. Did you actually mention the tolerance? Like what would be a reasonable tolerance?
No, I'm not entirely sure yet, as of yet, of what the tolerance would be. So like, I'm not sure how many microsieverts difference between the model and our calculations. I'm not entirely sure what would be considered high enough accuracy. So, but that will come later on, I guess.
Thanks, Martin. Roger?
Josh, that was really nice talk and very, very well explained. Thank you. And the NUMEX program, the NUMEX software, has a lot of promise, I'm sure. I've sort of watched its development, and at the coalface, having an instrument like that, calculation instrument, is so important. I've just got a couple of comments and then a question. In terms of iodine 131 and considering the release of patients and so forth, ablative doses can be much higher than the order of the 600 megabecs that you use for outpatient, for the standard outpatient thyroid disorders and so forth. The second one is that the very interesting question raised about tolerance. Tolerance is a difficult, what kind of error that you tolerate. And that really depends on whether it will change the directive given to the patient or how the medical physicist changes their work practice. And if the work practice or the directives are not changed, then it's within a certain tolerance. In other words, you're really interested to know what sort of variations would actually affect a change in the behavior of or the direction of the patient and so forth. And finally, my question is and this is born of ignorance, and I apologize for that, but the Numex software, I presume one of its functions would be to guide the medical physicist in their advice to the patientist and the patient's carer and so forth, and the physician involved as to how the patient can, when the patient can be discharged and how they will need to behave when they're out in the general community. Does the Numex software just simply provide hard numbers and then other calculations are done or other decisions are made on the result of those numbers? Or does or will Numex in the future actually provide kind of guides as to, for example, whether the patient can travel on a bus down to Albany, that sort of thing?
Yeah, so my understanding is that Numex just provides the numbers, and then that's up for the medical physicist to interpret the restriction periods. Whereas software such as Dawn actually has restriction periods like don't go to work for 5 days, or don't sleep next to a spouse for a week. But as far as I know, I don't think Numex currently has restriction periods. It just has the numbers.
Thank you.
Thanks.
We'll just have time for one more quick question. Ashleisha.
Thanks for the presentation, Josh. So my question was, how would you, so measurement of the point source and the line source might be a bit different because of like resolution and partial volume effects and such. So how do you think that would be tackled? And does like the software, do you know if the software deals with that as well?
So the line source and the point source will be the unattenuated exposures. So I plan on, I think I mentioned it, 2 sources used self-absorption factors. So I plan on looking and trying to add those attenuation factors to the point and line source to see how closely they correlate to the phantom source, which is representative of a real patient. So that's how I'm going to use those.
Okay, sounds good.
Mario, lucky last.
Thanks, Jake. Josh, well done. Very great presentation. I'm happy with that. I just wanted to give 2 comments because the activity question came up a couple of times. So basically, the activity was decided on a balance between safety. It can't be too high that we as the physicists get exposed too much during the measurements, but it also can't be too low that we get a low signal and a low uncertainty. So we've been deciding internally that we want to have at least 10 microsieverts per hour at 1 meter distance, which is roughly 50 times the background. And this is where those numbers, 3 gigs of lutetium, 128 megabecquerel of iodine came up with. And the second thing is Numex does provide advice to the physicist and to the staff. So when you use the software and you type in all the parameters, you get a number, yes, but also it exports a PDF with tailored advice for a certain situation, depending on which target audience you have, whether it's a carer, patients, physicists, and so on. But obviously, as Josh said correctly, this has to be interpreted still by the physicist to make a good call. But yeah, but other than that, thank you very much, Josh. And thanks, Jake, for letting me jump in at the end.
Thanks, Mario.
No problems. Thanks, Mario. And thanks, Josh. Excellent presentation and lots of questions.
Thanks.
I'll stop the recording. All right, brilliant.